السلام عليكم أعزائي الطلبة. سيمينارنا اليوم عن Aortic aneurysm من إعداد الطلبة حسين وعد الله خضر، أحمد منيف إدريس، ومروان عبد الله سلطان، طلاب المرحلة الثالثة في كلية طب الموصل بإشراف الدكتورة زهراء مروان.
Now, we will take introduction about the subject. An aortic aneurysm is a balloon-like bulge in the aorta. Aortic aneurysms can dissect or rupture. The force of blood pumping can split the layers of the artery wall, allowing blood to leak in between them. This process is called a dissection. The aneurysm can burst completely, causing bleeding inside the body. This is called a rupture. Dissections and ruptures are the cause of most deaths from aortic aneurysms. Types and classifications. Aortic aneurysm classified according to site as two main types, shape as two main types. As shape, as circular and fusiform. As site into thoracic aortic aneurysms, abdominal aortic aneurysms. Thoracic aortic aneurysms into root thoracic aortic aneurysm, ascending thoracic aortic aneurysm, arch thoracic aortic aneurysm, descending thoracic aortic aneurysm. Abdominal aortic aneurysms into suprarenal, pararenal, subrenal, and infrarenal. There are another classifications. These classifications used specially for thoraco-abdominal aneurysm. These classifications include Crawford classification, Stanford classification, DeBakey classification. طبعا Stanford and DeBakey for dissection, Crawford for aneurysm. This table in the slide shows that DeBakey and Stanford and their classification for dissection, Crawford and it is a classification for aneurysms, each according to its extent, especially for thoraco-abdominal aneurysm. This picture shows classifications and types according shape into fusiform aneurysm and circular aneurysm, according sites into thoracic aortic aneurysm and abdominal aortic aneurysm. This picture in the slide shows Crawford classification for thoraco-abdominal aneurysm. This is type 1, this is type 2, type 3, and type 4, according to its extent. Now, we will talk about pathogenesis. Pathophysiology depend on two main factors اللي هو الهيمودynamic and arterial walls weakness حتى نحصل arterial dilatation. طبعا arterial wall tension depends on Laplace law. Laplace law tension يساوي pressure multiplied by radius. So, increased tension is proportional to pressure and radius. حتى نحصل arterial dilatation لكن لازم يكون عندنا عاملين أساسيين. اللي هو ضغط الدم المسلط بواسطة القلب وضعف جدران الارتري. طبعا الارتيريال وول تنشن يعتمد على هذا القانون لابليس لو. Pathophysiology. The strength of arterial wall depends on its content of collagen and elastin fibers. So any change of these content lead to weakness of wall. This schematic picture in the slide show the effect of genetic factors and environment factors. These factors lead to destruction of elastin and collagen. The environment factor اللي هي الأثيروسكليروسيس والسموكينج والإنفلاميشن بالإضافة إلى الجينيتيك فاكتورز قد تؤدي إلى زيادة نشاط الإلاستيز، إنزيم الإلاستيز اللي بدوره lead to elastin destruction و failure of elastin. وجود ال environment factors اللي قلنا هي atherosclerosis و smoking و inflammation بالإضافة إلى genetic factors مع ال hypertension وال agent راح تعمل increased load on collagen fibers. هذا كلها بدورها هذه العوامل تؤدي إلى collagen remodeling وبالتالي failure of collagen. من حصلنا failure of elastin و failure of collagen راح نحصل aneurysmal dilatation واللي إذا ما تعالجت تؤدي إلى rupture. ننتقل للcauses and risk factors. diseases and unhealthy behaviors that damage your heart and blood vessels also increase your risk of aortic aneurysm. Smoking is the most important behavior related to aortic aneurysm. Other factors include high blood pressure, high blood cholesterol, atherosclerosis. This picture in the slide shows atherosclerosis in the wall of the artery, accumulation of fat in the wall. Other factors may be some genetic factors which include Marfan syndrome and Ehlers-Danlos syndrome. طبعا these three pictures show this Marfan syndrome, enlargement of the heart. In Marfan syndrome, the enlarged aorta can eventually lead to tears or an aneurysm. These two pictures show Ehlers-Danlos syndrome. طبعا هاي الحالة وراثية واللي جينيتك يكون خربطة بيها بالأربطة، نقص بالكولاجين وبالإلاستين. لهذا السبب يكون ضعف الأربطة. Other factors. Family history can also increase your risk for aortic aneurysm. Your family may also have a history of aortic aneurysm that can increase your risk. Another factors include blood vessel disease. This disease that causes blood vessel to become inflamed, infection in the aorta, rarely. طبعا infection بالأورطة غالبا نادرا ما يكون rarely bacterial or fungal infection might cause an abdominal aortic aneurysm. Trauma, for example, being in a car accident can cause an abdominal aortic aneurysm. يعني الفاميلي هيستوري والبلاد فيزل ديزيز والانفكشن بالاورتا والتروما، هاي كل عوامل تؤدي الى حصول الاورتيك انيوريزم. طبعا اكو عوامل اخرى اللي هي الايج، الاشخاص اللي يكونون بعمر 65 فما فوق يكون اكثر عرضة للاورتيك انيوريزم. الجنس، طبعا بالرجال اكثر من النساء. being a white، طبعا الاشخاص البيض يكون اكثر عرضة للابدومينال aortic aneurysm. other aneurysms، يعني اذا عنده aneurysm بغير مكان، having an aneurysm in another large blood vessels such as the artery behind the knee or aorta in the chest might increase your risk of an abdominal aortic aneurysm. Other factors or other medical condition: inflammatory conditions such as giant cell arteritis and Takayasu arteritis are associated with thoracic aortic aneurysm. Problem with your heart's aortic valve، طبعا هاي مشكلة أساسية أو مشكلة صعبة. The problems with aortic valve، دائما أصحاب هذا المرض يكونون معرضين للthoracic aortic aneurysm. Some people who have problems with the valve that blood follow through as it leaves the heart, such as aortic valve, have an increased risk of thoracic aortic aneurysm. This is mainly true for people who were born with an aortic valve that has only 2 flaps instead of 3, bicuspid aortic valve. يعني الأطفال اللي يولدون وعندهم 2 flap instead of 3 flap or bicuspid aortic valve، هذول يكونون أكثر عرضة للthoracic aortic aneurysm. Untreated infection، though rare، بالرغم من أنها نادرة، it is possible to develop a thoracic aortic aneurysm if you have had an untreated infection such as syphilis or salmonella. Now I will let you with my colleagues to complete the seminar.
Assalamu alaikum warahmatullahi wabarakatuh. My name is Ahmed Munif. I am third medical student. Now we continue about morphology of aortic aneurysm. An aortic aneurysm is a balloon-like bulge in the aorta, the large artery that carries blood from the heart through the chest and the trunk. Aortic aneurysm can dissect or rupture. The force of blood pumping can split the layers of the artery wall, which are tunica intima, media, and adventitia, allowing blood to leak in between them. Aneurysm, localized abnormal dilation, circular or fusiform of blood vessels or the wall of the heart, classified into true or false. In this figure, A. Normal vessel. B. True aneurysm, circular type. The wall bulges outward and may be attenuated, but is otherwise intact. C. True aneurysm or fusiform. There is circumferential dilation of the vessel. D. False aneurysm. The wall is ruptured, creating a collection of blood or hematoma bounded externally by adherent extravascular tissue. And E. Dissection. Blood has entered the wall of the vessel and dissected the layers. Morphology of aneurysm, either circular or fusiform. Circular, the wall bulges outward. Fusiform, circumferential dilation of the vessel. Abdominal aortic aneurysm, rare, less than 50 years, more in males, position between renal artery origin and bifurcation of aorta. Either circular or fusiform, up to 15 cm in diameter and 25 cm in length. In this figure, abdominal aortic aneurysm, A. External site of rupture of large aortic aneurysm. B. Open aorta with location of rupture tract indicated by a probe. The wall of the aneurysm is attenuated and the lumen is filled by large layered thrombus. So, abdominal aortic aneurysm, transverse or oblique intimal tear. So, abdominal aortic aneurysm, dissection extends proximally and distally. So, elastic fibers fragmentation with elastic Van Gysson staining. The biopsy demonstrates significant degradation of extracellular elastin. So, in this figure, A, B, and C, A, cystic medial degeneration with hematoxylin eosine staining. B, adventitial inflammatory infiltrate and thickening of the vasa vasorum with hematoxylin eosine staining. And C, dissecting aneurysm with hematoxylin eosine staining. Histological examination demonstrates that pathophysiological processes in aortic aneurysm involve all layers of the aortic wall, contrasting to those observed in occlusive atherosclerosis. The biopsy demonstrates significant degradation of extracellular elastin and collagen fibers, cystic medial change in figure A, and fibrosis, reduction in the number of vascular smooth muscle cells, medial and adventitial infiltration by mononuclear lymphocytes and macrophages forming vascular associated lymphoid tissue, a thickening of the vasa vasorum in the figure B, and an increase in medial neovascularization has also been reported in aneurysmal tissue biopsy. Moreover, medial splitting by hemorrhage associated to elastic fragmentation and fibrosis was observed in dissecting aneurysm. Cystic changes are characterized by accumulation of basophilic material in hematoxylin eosine staining, showing blue positive and metachromatic characteristics between the elastic lamella of the aortic media. Occasional elastin deposits are identified in area with fibers disruption or severe fragmentation when associated to lesion. Thanks.
Assalamu alaikum. I am Marwan Abdullah Sultan. I will continue with the clinical presentations. Now, with the thoracic aortic aneurysm. The majority of patients with thoracic aortic aneurysm are asymptomatic. So, the patient has no any mark of disease. But when the signs and symptoms have been developed, we can see the following presentations. Aortic rupture. Tears in the wall of aorta and rupture of the aorta are the main complications of thoracic aortic aneurysm. A ruptured aortic aneurysm can lead to life-threatening internal bleeding. In general, the larger the aneurysm, the greater the risk of rupture. Pain in the chest or may radiate into the back. The pain is described as a tearing. It's caused by erosion of bone, like ribs and vertebral bodies. Persistent cough from irritation of the recurrent laryngeal nerves. Shortness of breath due to compression against the airway. Difficulty of swallowing due to compression against the esophagus. Compression on mediastinal structures, so the patient has respiratory or feeding difficulties due to airway or esophageal compression respectively. Hoarseness, بحة أو خشونة في الصوت due to extension in the recurrent laryngeal nerve which wraps around the aortic arch. Cardiac disease due to valvular insufficiency or narrowing of the coronary ostia. Now we finished all symptoms retaining to thoracic aortic aneurysm. So we will continue with abdominal aortic aneurysm. As I said, in thoracic aortic aneurysm, the majority of patients are asymptomatic, so the patient has no any mark of disease. But when the signs and symptoms has been developed, we can see the following presentations. Rupture. The aneurysm may be ruptured into the retroperitoneum, the peritoneal cavity, leading to massive and even fatal hemorrhage. Also may rupture into surrounding structures, most commonly the inferior vena cava, leading to an aortocaval fistula. Pain. The patient may present with pain in the central abdomen, back, iliac fossa, loin or groin regions, and best described as feeling of rupture. Abdominal mass, often palpably pulsating, that stimulates a tumor. Compression on adjacent structures. The expansion and distension that result from aneurysm can compress the surrounding structures such as the duodenum. This can cause obstruction and vomiting. Also, the aneurysm can press on the inferior vena cava. So, the edema and deep venous thrombosis may result, or it can compress the ureter or erosion of vertebrae. Obstruction of vessels branching of the aorta, like renal, iliac, vertebral, or mesenteric arteries, resulting in distal ischemia of the kidneys, legs, spinal cord, or gastrointestinal tract, respectively. Thromboembolic complications. Thrombus within the aneurysm sac may be a source of emboli to the lower limbs. Less commonly, the aorta may undergo to thrombotic occlusion. This is all about clinical presentations. Now we will continue with the diagnosis. The thoracic aortic aneurysm can be diagnosed by taking complete and proper history from the patient, so we can note the signs and symptoms that can predict and detect presence of thoracic aortic aneurysm. Also, the clinical examination can help us in the diagnosis. Then we can ask the patient to take screening for his or her chest by X-ray, echocardiogram, ultrasound, CT scan, MRI, or genetic testing, whether there is history of aneurysm in his or her family or another suspected genetic condition that raises risk of thoracic aortic aneurysm. Now, with the diagnosis of abdominal aortic aneurysm. As with a thoracic aortic aneurysm, detection of abdominal aortic aneurysm sometimes from taking history when we note presenting most clinical features. Also, during a routine examination, especially when we detect abdominal mass, also we can take abdominal ultrasound to the patient, especially if the patient was a man from 65 to 75 years old who has ever smoked, or he has more chances of getting an aortic aneurysm. Also, we have CT scan and MRI. References, and thank you very much for your listening.